the speakers had to upload them at the speaker preview room. Maybe
So
it's good to check with them if they have.
Kick us off.
Yeah, let's start.
Close the door. So, colleagues, friends, a very good morning and welcome to this exciting session. My name is Marleen Temmerman. I'm an obstetrician gynecologist working with the Aga Khan University based in Nairobi, Kenya since many years. I have a long history working in HIV and infectious diseases and maternal health. And I'm a member of the EDCTP 3 Scientific Committee. I have the pleasure to co-chair this session together with Johanna, who will introduce herself. We have 6 speakers today, so we propose that each of you will take 12 minutes for presentation, 5 minutes for Q&A, and we hope that we have some time at the end so that we can still have a plenary Q&A, 5 to 10 minutes. Johanna?
Yeah.
The floor is yours.
Thank you. Thank you, Marleen. My name is Johanna Schäfer. I'm a project officer at the EDCTP2 program. And I have a background, actually, a PhD in child and adolescent mental health, slightly different, but also important topic, of course, and also in infectious diseases. I'm dealing with a lot of grants in the HIV area at the EDCTP from the EDCTP funders' point of view. So, I'm very excited about this session. I think we have an interesting topic and 6 speakers today who will present to us. So we don't want to take too long for the introductions, just a little housekeeping to please put your phones on silent so that we do not get disturbed during the session. And let's go ahead and start with our first presentation for today. I'd like to ask Roslyn Telingwani, please, to take the stage. And she is from Zimbabwe, from the African Institute of Biomedical Sciences and Technology. And she will present to us on drug-drug interactions today. And please go ahead.
The presentation. Oh.
Can we get the slides? Sorry. Okay, great.
Thank you. Okay, so good morning, everyone. My name is Roslyn Telingwani. I'm from the African Institute of Biomedical Science and Technology in Harare, Zimbabwe. The title of my presentation is Clinically Relevant Enantiomer-Specific RNS Praziquantel Pharmacokinetic Drug-Drug Interactions with Efavirenz and Ritonavir, Implications for HIV and Schistosomiasis co-infection. So just to give you a background, schistosomiasis is a disease that infects approximately 250 million people, and it is estimated that 20,000 deaths occur annually. 235 million people are treated through MDA approximately, and WHO targets to treat about 79% of 800 million people who are at risk of schistosomiasis. And this is the only drug that is currently effective against all forms of schistosomiasis, and the current WHO recommended drug for mass drug administrations and for treatment of schistosomiasis. And it occurs as a racemate, the R and the S praziquantel. And it is the R praziquantel that is the effective form of the drug, although there is some activity in the S enantiomer. The S enantiomer, being the less effective, is also associated with the bitterness of the tablet. And why these 2 diseases are of importance is that they share an epidemiological space, especially where you find schistosomiasis to be endemic, you also find HIV. And the risk of co-infection is very high between the 2 diseases, hence our interest in the drug-drug interaction. And as you can see from the pictures, that is the map in blue, a map showing the prevalence of HIV and the distribution of schistosomiasis in green. And in a paper we published, what we realized of the two enantiomers was that they are specific in the type of enzymes that metabolize them. The R praziquantel is mainly metabolized via CYP3A4, CYP3A5, whereas the R praziquantel is metabolized via the CYP1A2 to C9 pathway, whereas the S praziquantel is mainly via the CYP3A4 pathway. This has implications on the type of drug-drug interactions that occur depending on which enantiomer you are interested in, either the S or the R praziquantel. And also the metabolites for the 3A4 pathway, it is mainly the X-hydroxy, which is still to be identified, the X-hydroxypraziquantel, whereas the other pathway is the normal 4-hydroxypraziquantel that has been previously published. So the aims and objectives of this work was to evaluate the extent and nature of drug-drug interaction in the co-treatment of HIV and schistosomiasis. And we set out to conduct a clinical study to measure the effect of efavirenz and ritonavir on the pharmacokinetics of praziquantel in healthy volunteers. Efavirenz is a known inducer of 3A4 and many other CYP enzymes, and ritonavir is an inhibitor of CYP3A4. And for our study design, this was an open label single dose, one sequence crossover study with 2 arms. And in arm 1, we had praziquantel alone and in the presence of efavirenz. And in arm 2, we had praziquantel alone, and then we switched on to praziquantel and ritonavir. And the R and S praziquantel concentration in the plasma was determined using LCMS, and we did the statistical analysis in Win-Onlin for the PK parameters, and we used the half-life, the C-mean, and the area under the curve as our primary endpoints. And what we were just trying to find was whether after the drug-drug interactions, our praziquantel would either end up in the therapeutic window, which is the desirable, or if we would see elevated concentrations, of course, being the toxic concentrations, or subtherapeutic concentrations in the case of induction by efavirenz. And these were our results. What we found out was that the R praziquantel was metabolized more than the S praziquantel, as has been previously published. And what we realized, there was no big effect on the S praziquantel. And on the R praziquantel, which is more metabolized, as you can see from the diagram, almost all the patients where we had the drug concentrations analyzed had concentrations that were in the subtherapeutic were in the subtherapeutic range. And this basically means that for patients that are being treated with praziquantel, whilst they are on an efavirenz-based regimen, they will have subtherapeutic and probably poor treatment outcome if the drugs are given together. And with ritonavir, we did not see any significant effect on the R praziquantel, and with only a 2-fold increase in the area under the curve for S praziquantel. So what does this mean? What this study would add is a knowledge towards the safe and efficacious use of praziquantel, especially in cases of co-infection. And as we have noticed in Zimbabwe and many other African countries, we conduct annual mass drug administrations where praziquantel is administered to all children of school-going age, and it is administered with no prior knowledge of what the kids are on, and this has implications on children who are HIV infected. So knowledge from this would better guide design of mass drug treatment programs where HIV status of an individual as well as the concomitant drug intake has not been taken into consideration prior to administration. And if this is taken into account, we expect to see better treatment outcomes for HIV patients in schistosomiasis endemic regions. And this might also influence a change in the product label. Currently, there is there is highlight of rifampicin where a drug-drug interaction between praziquantel and rifampicin has been observed, and there is a caution in the concomitant intake of rifampicin and praziquantel, and this may also be extended to efavirenz and other potential inducers for this drug. And also with the recent IAR praziquantel, it could also be used to either design a boosted regimen where we can be more sure that all the patients are getting adequate doses. So it could guide in a design where instead of using, because it has always been currently known that praziquantel is metabolized via the CYP3A4 pathway, but this is the R form. And from our studies, we've realized that it's actually metabolized via CYP3A4, CYP1A2, and CYP2C19. So a boosted regimen using CYP1A2 and CYP2C19 inhibitors instead of the previously explored CYP3A4 inhibitors would be helpful. So I would like to acknowledge my supervisor, Professor Masemirembwa, my study teammates, the IBIS clinical team, EDCTP for funding my participation, and the other organization for funding the study. Thank you so much for paying attention.
Thank you very much, Roslyn, for this very interesting presentation. And I think it's really important to see these results. So I just want to invite everybody to ask questions. Put up your hand. There are some microphones in the room. Thank you.
Thank you very much for the great presentation. On one of your slides, you gave 2 maps to talk about the prevalence. And the prevalence map was for 2015. Is it because there hasn't been any publication of new maps since then?
It was an oversight on my part. There should be newer ones.
Okay, thank you.
Thank you, Dr. Roslyn, for your presentation. I'm Seliji from Lambaréné, Gabon. I'm very, very impressed, and I want to know where and who performed the assays.
So all the assays were performed at the African Institute of Biomedical Science and Technology, and these were the main, that was the people I've acknowledged formed part of the study team, so everything was done in Harare, Zimbabwe.
Okay, thanks.
Yeah, thank you very much, Rosalind. That was excellent. Since we are no longer using efavirenz widely, except in a few cases, are you going to consider doing what we are using now, DTG-based regimen, so that, I don't know whether this was your PhD, are you going to do a postdoc in some other, I'm impressed the way you are growing, and it would be nice if you add on something that we are currently using to see whether it's affected by these drugs.
So at the time when we conducted this study, we still had efavirenz-based regimen, and some of them are still, but I do get what you mean, that efavirenz is being phased out, but it would still be interesting for other drugs that are still using the same pathway, which are where you have co-infection and they still use the same pathway, the CYP1A2 and 2C19 pathway, to explore potential drug-drug interaction. This was a good pilot to show that it can potentially lead to less effectiveness of a drug if two drugs are concomitantly given and you don't pay attention to which pathway they are both using and the potential drug-drug interactions they may have.
Maybe one last question.
Yeah, thank you, Rosalind. Very impressive work and congratulations. Mine is a simple question. Just some more clarification on the two forms of praziquantel. You say the RI enantiomer and the S enantiomer for somebody who's not acquainted with those terms. Can you just explain more about these two formulations? Thank you.
So the drug is given as a racemate, which means it occurs in the two forms, the R and the S, and they occur in proportions of 50-50. So it's just two different forms of the drugs, of the drug. So the praziquantel that has previously been used is the racemate. That's the racemate. It's a mixture of the two forms. However, there is a new formulation that is currently being developed, which is the praziquantel, which is a formulation that is in development, targeting the school age going children, like 2 to 6 years. Yeah. But currently, it's the two forms. It's a racemate. It's in a proportion of 50 to 50. Yeah, half. Yeah.
Thank you very much, Rosalind, for this excellent presentation.
Thank you.
And our next speaker in the program is Georgia. I would like to welcome Georgia Schaefer from the International Center for Genetic Engineering and Biotechnology from South Africa to now give her presentation. Thank you.
Okay, thanks very much, and good morning to everyone. I'm based at the ICGB in Cape Town, South Africa, and I'm also an EDCTP Senior Fellowship recipient on research that looks at reactivation of the oncogenic virus Kaposi sarcoma herpes virus, or KSHV, by co-infections and inflammation in HIV-infected patients. So just to give you a bit of background on the virus I'm focusing on, KSHV is a large envelope double-stranded DNA tumor virus of the herpes virus family, which is rather rare in Europe and North America, but highly endemic in sub-Saharan Africa. And it's primarily submitted by oral transmission in childhood, by mother to child via saliva. And it infects primarily endothelial and B cells, which can then give rise to certain malignancies, such as sarcomas and lymphomas. As is true for all oncogenic viruses, infection with KSHV is necessary for malignancy development, but not sufficient. And for cancer development, precipitating factors are required. And in the case of Kaposi sarcoma, HIV co-infection and immunosuppression is the most important one. So, as I just mentioned, Kaposi sarcoma is the most common AIDS-related malignancy worldwide. Also typical for herpes viruses is the biphasic life cycle. So there's a latent and a lytic phase in the KSHV infection cycle. The gene products from both phases are important for the establishment of persistence of the virus in the host, and both gene products from the two phases are important for the development of malignancies. So as I mentioned, KSHV is highly prevalent in sub-Saharan Africa, which was even the case before the onset of the HIV/AIDS epidemic. But as we all know, HIV/AIDS also occurs primarily in sub-Saharan Africa, and as I mentioned, HIV co-infection is the most common risk factors for the development of Kaposi sarcoma. No surprise, Kaposi sarcoma is also has the highest incidence in sub-Saharan Africa. But Kaposi sarcoma and endothelial cell tumor is not the only KSHV-associated pathologies. There's also others, primarily in the context of HIV co-infections, such as primary infusion lymphoma, a B-cell malignancy. And importantly, both these conditions are associated with latent KSHV infection, which means patients typically do not present with elevated KSHV viral load in the blood. And this is different to multicentric Castleman disease and KSHV inflammatory cytokine syndrome. Here, patients present with inflammatory symptoms such as fevers, night sweats, wasting, etc. And in these two conditions, KSHV primarily occurs in the lytic phase of the cycle, so patients present with elevated KSHV viral load in the blood and a number of overproduced inflammatory markers. So these inflammatory conditions I just mentioned, wasting, night sweats, fevers, etc., are all quite unspecific and often mimic other conditions that are highly prevalent in our context, like tuberculosis and more recently COVID-19. And I will show you some examples of current research where we looked at the contribution of KSHV to those very prevalent infectious diseases in sub-Saharan Africa. And we're also going to look at KSHV in the long term after the COVID-19 pandemic has ended. So previous published work was a study on patients presenting on TB, and as we all know, TB is also highly prevalent in sub-Saharan Africa. And because patients are presenting with these typical symptoms, fevers, night sweats, coughing, weight loss, etc., they are treated for TB, but almost 25% of patients do not have a microbiologically confirmed TB diagnosis. And due to the high prevalence of KSHV in our context, we asked whether maybe a KSHV lytic infection might play a currently under recognized role in morbidity and mortality in patients that are presenting with typical TB symptoms. So we had retrospective access to a patient cohort that was recruited in the context of a TB study. They were all HIV infected and critically ill. They all had a high HIV viral load, low CD4 count. More than 20% of the patients died within 12 weeks, so they were all hospitalized. And again, in terms of TB diagnosis, although it was done extensively, only 75% of the patients had a confirmed TB diagnosis. So we asked whether KSHV viral load might be associated with this high mortality in the patient cohort. And first of all, we looked at the entire patient cohort and measured KSHV viral load in the blood. We did see an elevated KSHV viral load in the patients who died compared to those who survived, but this was not statistically significant. And we thought because of the high prevalence of TB, this might probably mimic or mask any KSHV-associated mortality. And that's why we excluded patients with proven TB, only looked at patients with not proven TB, or also excluded those with any other proven co-infection. And we did see that patients who died have a statistically significant higher KSHV viral load compared to those patients who survived. And these four groups of patients we also looked at a little bit differently, where we categorized the KSHV viral load into elevated, which was more than 100 copies per 10 to the 6 cells or below. And again, focusing on group 4 patients, those without microbiologically confirmed TB or any co-infections, we did see a significant association with elevated KSHV viral load and mortality with an odds ratio of more than 7. So just to conclude this study is we do see that elevated KSHV viral load is associated with mortality in a specific context. In this context, it was critically ill patients presenting with TB symptoms but did not have microbiologically confirmed TB. And we think that in a specific context like that, KSHV viral load might have a strong prognostic value for patients that are investigated for TB but do not have TB. Another example I want to show you is more recent. COVID-19, of course, also in severe cases, presents with high inflammatory markers. And again, we asked whether KSHV infection, especially the lytic KSHV infection, might impact on COVID-19 severity and outcome. And here we looked at a patient cohort that was recruited during the first COVID-19 wave in South Africa between July and August 2020. All patients were hospitalized with severe COVID, all were PCR confirmed. And just to highlight a few demographics, about 30% of the patients were HIV infected. We had about 40% KSHV seropositivity, 20% KSHV viral load that was detectable in the blood. As I said, they were all severely ill and also had high COVID-19 severity score. About a third of the patients died. They presented with a number of comorbidities, and also in terms of laboratory abnormalities, they presented with high inflammatory markers. So looking at the question whether KSHV viral load might play a role in COVID-19 severity and outcome, we applied 2 severity scores. One was the WHO severity scale and the other one a principal component analysis. In both cases, we see that patients who died had a higher, patients with more severe COVID had higher KSHV viral load, but this was not statistically significant. But when we looked at outcome, we did see that a higher percentage of patients who died had detectable KSHV viral load in the blood. And we also wanted to further interrogate this univariate association between KSHV viral load and death, and performed this logistic regression for death as outcome, controlling for a number of demographic variables as well as severity. And we did see that detectable KSHV viral load was significantly associated with mortality in our patient cohort with an adjusted odds ratio of 4.5. So just to summarize this example is that we again see a potential contribution of lytic KSHV infection to COVID severity and outcome. Of course, this is just a snapshot in time. This correlation does not explain causation, so we don't know whether it was SARS-CoV-2 infection or the COVID-related cytokine storm that led to lytic reactivation, or whether patients who already had lytic reactivated KSHV had more susceptibility to adverse COVID-19 outcomes. So this is current research in progress. So this brings me to the end of the talk, where I want to show you some unpublished work, where we look at long-term effects of SARS-CoV-2 infection on KSHV reactivation in a more healthy cohort. So the two examples I showed you were in hospitalized, critically ill patients. Now we move on to a patient cohort that was recruited in an ART clinic just outside Cape Town, where patients present for routine HIV care, so they were not hospitalized, and recruited patients from September 2020, which was just after the first COVID-19 wave in South Africa, throughout all the subsequent waves until April 2023, including rollout of vaccinations in South Africa. And what I would also like to highlight is that patients lived in very densely populated areas. So during COVID, there was basically no social distancing possible. So these patients were highly exposed to SARS-CoV-2 infection throughout all the waves where we performed the recruitment. A few demographics: all patients were HIV infected. As I said, they attended routine HIV care. The majority received ART and, of course, also had suppressed HIV viral load, more than half of the patients. In terms of KSHV seropositivity, more than 50% had antibodies against KSHV, and by the end of the study, we had about 20% of patients with detectable KSHV viral load in the blood. We had higher SARS-CoV-2 seropositivity in the end of more than 80%, and about a third of the patients self-reportedly to be vaccinated against COVID. So when we looked at SARS-CoV-2 serology, as I said, these patients were highly exposed to SARS-CoV-2. And right at the beginning of the study in October 2020, we already had 75% of patients that were exposed to SARS-CoV-2. And this steadily increased over the course of the recruitment period, reaching almost 100% by the end due to repeated SARS-CoV-2 infection waves as well as rollout of vaccinations. When we looked at KSHV serology, we did not see changes over the recruitment period. There were some fluctuations, but nothing that was any significant. But what was really interesting was the KSHV viral load. So in the beginning of the recruitment, we had only a very few patients that showed detectable KSHV viral load in the blood. And then from early 2022, we see an increase in patients with reactivated KSHV, which was quite puzzling. And we thought maybe this is due to repeated infection waves or rollout of vaccinations. And that's why we divided the patient cohort into vaccinated and unvaccinated patients. And when we looked at SARS-CoV-2 serology, you can see with the gray bars that SARS-CoV-2 antibodies steadily increased over the recruitment period in the unvaccinated patients, probably because of repeated exposure to SARS-CoV-2 infection, while the vaccinated patient had a higher SARS-CoV-2 antibody level, which stayed pretty constant over the recruitment period. We further divided the patient cohort not only in vaccinated and unvaccinated, but also into whether KSHV viral load was detectable or not. And what we can see here is that there were higher SARS-CoV-2 antibody titers in the unvaccinated patients with detectable compared to undetectable KSHV viral load, which we did not see in the vaccinated patient cohort, which had very high SARS-CoV-2 antibody levels anyway, as I mentioned just now. Interestingly, we did not see any difference in inflammatory markers. We looked at CRP and IL-6, but whether patients are vaccinated or not, or had KSHV viral load or not, we did not see any differences. So to further interrogate this univariate association between KSHV viral load in the unvaccinated patients and SARS-CoV-2 antibody titers, we performed a logistic regression in the two patient groups, the vaccinated and the unvaccinated, controlling for a number of demographic parameters as well as variables that were significant in the univariate level. And I just want to highlight this. So we see a statistically significant association between SARS-CoV-2 antibody titers and KSHV viral load in the unvaccinated patient cohort, but not in the vaccinated patient cohort. And the other interesting result we see is abnormal lymphocyte count. So we see lower lymphocytes in the unvaccinated patients who had a KSHV viral load detectable, but not in the vaccinated patients. So what we think, because our SARS-CoV-2 antibody titer is just a proxy for previous SARS-CoV-2 infection in the unvaccinated patient, we think that it's the exposure to SARS-CoV-2 and probably multiple or repeated exposure to SARS-CoV-2 in those unvaccinated or unprotected patients that lead to reactivation of KSHV as well as also lymphopenia. And what we think is that post-pandemic prevention or monitoring strategy of potential KSHV-associated pathologies in these high-risk patients, or in other words, in the HIV-infected immunodeficient patients, is highly recommended. Just to overall conclude, In the first two published examples, I showed you patients that were hospitalized with critically ill inflammatory symptoms. And we see both in the context of a TB study and a COVID-19 study that KSHV viral load was associated with adverse disease outcome. And we think that implementation of KSHV diagnostic testing in high-risk patient groups is a useful tool to implement. In the context of non-hospitalized patients with impaired immune functions, such as in a routine HIV care clinic, we see that increased KSHV lytic reactivation due to repeated SARS-CoV-2 infection, but not due to vaccination, is an observation. Currently, we don't have any indication of adverse disease outcome. We only see that in our patients, more and more patients present with KSHV viral load. But this can have long-term consequences because KSHV-associated malignancy might develop only years after exposure or reactivation. And we think that monitoring of selected patient groups for long-term outcomes after the COVID-19 pandemic are highly recommended. So with that, I would like to acknowledge all individuals that were involved in these studies, particularly my postdoc Melissa Blumenthal and my PhD student Tomero Lamberé, as well as also other collaborators. Some of them are also EDCTP grant recipients. And of course, I thank the EDCTP for funding my studies, as well as all other funders. And I thank you for your attention.
Thank you very much, Georgia, for this very interesting presentation. So, any questions from the room? I think there will be a few.
Thank you so much for your presentation. It's a very exciting science that you've done. I see you compared the vaccinated and unvaccinated groups for COVID-19. And you see high viral load for KSHV in the unvaccinated group. But we know that the COVID vaccines did not prevent infection. So I don't know in your vaccinated group whether you didn't encounter those who got reinfected even after vaccination, and whether that has an effect on the KSHV viral load that you were able to measure.
So the vaccinated group, of course, we only have SARS-CoV-2 antibody titers as a proxy for either previous exposure to SARS-CoV-2 or vaccination. So the vaccinated group does contain individuals that were infected as well as those individuals that were vaccinated. That's why they had SARS-CoV-2 antibody titers. So we can't distinguish that. The fact that we see this association in unvaccinated groups and we use SARS-CoV-2 antibody titers as a proxy for previous SARS-CoV-2 exposure tells us that it must be a biological downstream effect of SARS-CoV-2 infection, maybe on immune cell level, etc., that might lead to the reactivation of KSHV. So yes, you are right, the vaccine does not prevent reinfection of SARS-CoV-2, but it prevents other biological downstream effects of SARS-CoV-2 infection on a more immunological level, and the unvaccinated patients are unprotected against these effects.
But what proportion of the unvaccinated have this spike of KSHV viral load? Is it all of them or just a proportion?
No, it's only a proportion, and we see this towards the end of the recruitment period. By the end, so I showed you that one slide where we always look at quarters, always 3 months periods, and by the end of the recruitment period, we see like 60% or so of the patients with detectable KSHV viral load. Also, I'm saying detectable because it's not necessarily elevated. It's many patients that suddenly show some KSHV viral load in the blood, but it's often low enough that it does not cause any inflammation. But this is just sort of also a certain period of time that we are investigating. We are continuing and also follow up certain patients. And as I said, maybe KSHV has long-term repercussions leading to KSHV-associated pathologies.
Thank you. We shall talk later.
Okay.
Thanks for a very nice talk. Have you thought about CMV, which is another herpes virus, which could mediate or confound the association that you're observing between KSHV and mortality? As you know, that progression of HIV and mortality association with CMV is really recognized. Thanks.
Yeah, we haven't looked at CMV. We are considering looking at EBV because it's a related oncogenic herpes virus, but we haven't looked at CMV.
Thank you very much. Is there, we can maybe have one last question, or otherwise, if there's none, then I would suggest we move on to the next talk. And I want to just remind the virtual participants that it is also possible to send us your questions through the virtual environment. Thank you very much, Georgia, again. Yeah. And next on the program, I would like to invite Edith Majonga from the Biomedical Research and Training Institute in Zimbabwe to give her presentation on myocardial structure and function assessed by cardiac magnetic resonance in adolescents with perinatal acquired HIV infection, taking ARVs.
Good morning, ladies and gentlemen. My name is Edith Majonga, and I'm from the Biomedical Research and Training Institute in the through Zim research group. We just won an award this morning, and I'm very proud to be part of the group. My talk this morning is on myocardial structure and function assessed by cardiac magnetic resonance in adolescents with perinatal acquired HIV infection and taking antiretroviral therapy. Such a mouthful. Antiretroviral therapy, as we all know, has significantly improved survival in people living with HIV, and as such, many children living with HIV are now surviving into adolescence and adulthood. So HIV is associated with increased chronic comorbidities, including cardiac disease. And in this era, we have seen that cardiac manifestations have predominantly been subclinical, existing on a spectrum, heterogeneous, and may differ between adolescents and older adults with HIV. So we do have vast evidence, extensive evidence on the burden of cardiac abnormalities in young people, which is, and they've been investigated using echocardiography. So echocardiography is a great tool, but it may be less sensitive and is limited in tissue characterization abilities. Cardiac magnetic resonance imaging is a powerful diagnostic tool which accurately assesses cardiac structure and function and is able to show subtle myocardial alterations. So the aim of this study is to investigate myocardial structure and function in adolescents with perinatal HIV and established on ARTS and using advanced imaging with cardiac magnetic resonance. So this is a cross-sectional study which is enrolling adolescents with HIV aged between 10 and 19 years on ART for at least 6 months and a negative control group for comparison. The study is being conducted at a tertiary public hospital in Harare called Salim Mugabe, and we're targeting a total sample size of 120 participants, 60 with HIV and 60 that are negative. We are performing cardiac magnetic resonance scans on a 3 Tesla MRI system called Canon Vantage Galant 3T in Harare, acquiring cine images for ventricular volumes, function, cardiac mass, and morphology evaluation. We're also performing late gadolinium enhancement imaging to assess any presence of myocardial scarring. Images are being analyzed using the CVI-42, which is a dedicated software for performing measurements on cardiac MRI scans. We're also performing anthropometry and blood sampling for biochemical, immunological, and virological assessments. So we have so far enrolled 46 adolescents with HIV and 42 negative controls. And adolescents with HIV are older, but the body surface area between the two groups is similar. Adolescents with HIV have got a much lower height for HZ score and weight for HZ score, suggesting that they're more stunted and wasted. And we have about 67% of adolescents with HIV being virally suppressed, that is having a cutoff of less than 20 copies per ml. This is a unique cohort of adolescents with HIV because they've had delayed diagnosis of HIV. The median age of HIV diagnosis is about 5.5 years. Looking at the MRI findings, adolescents with HIV have increased left end diastolic and systolic indexed volumes compared to negative controls, and they've also increased left ventricular mass index, and we have reported no late gadolinium enhancement in both groups so far. We also found that adolescents who are virally unsuppressed have reduced left ventricular ejection fraction and right ventricular ejection fraction, and they also have a lower peak global circumferential strain, which is the most subtle measurement of function compared to the suppressed group. In conclusion, adolescents living with HIV have increased left end diastolic and systolic index volumes and increased left ventricular mass index. We also found that unsuppressed viral load is associated with reduced right and left ventricular systolic function and peak global circumferential strain. All of this is suggesting that myocardial structural and functional changes are present in these young people despite art. This is an interim analysis, and recruitment is still ongoing with comprehensive regression modeling planned for the future. Also have biomarker results pending, and we anticipate that these will be able to elucidate potential pathogenic mechanisms that are driving these changes that we're already seeing in these young people. I'd like to acknowledge EDCTP for funding this project, study participants, my institution, Biomedical Research and Training Institute, my mentors, and other collaborators who have made this work a success. Thank you.
Thank you very much, Edith, for this nice presentation. Any questions from the room? I see a hand up over there. Is there still a microphone? Otherwise, there are some microphones in the back as well. But then you have to get up. I'm sorry.
Thank you for this presentation. My question is, we know that between HIV, between HIV infected, HIV negative, HIV exposed but uninfected children, they might be a different outcome regarding your exploration of cardiopathy. So within the group of HIV negative children, have you been able to see the outcome of those who are exposed but unaffected? Thank you.
In this particular study, no, but yes, I agree with you. There's evidence that they may also have, they are also at risk of cardiac disease, having been exposed to HIV or antiretroviral therapy. So it is, we did think about it, but it is a bit difficult now with the new, it was difficult to just get negative controls where they've been exposed but uninfected.
There's another question, I think.
Yes, please. Jean-Pierre Molès, Montpellier, France. You mentioned that you will analyze some biomarkers, but you didn't detail them. So can you
okay.
more?
All right, thank you. We are interested in looking at inflammatory biomarkers and fibrotic biomarkers because we're also interested in knowing the tissue characterization, if there's any scarring in the myocardium tissue. So we'll look at specifically ST2 and galectin-3 for fibrosis. And we'll also look at inflammatory markers, IL-6, TNF-alphas. Yeah, just to mention a few.
Thank you. If there are no more questions, then thank you very much, Edith, for this presentation again. Yeah, I'm very happy to fund this project.
Thank you so much. And it's my pleasure to call upon the next presenter, that is called Jane Kabami from the Infectious Disease Research Collaboration in Uganda. She is going to present the multi-component integrated HIV-HTN care model, improves hypertension screening and control in rural Uganda. Jane, the floor is yours.
Yep, thank you so much for your kind introduction. Again, my name is Jane Kabami, and I come from the Infectious Diseases Research Collaboration. And I'll be sharing with you a presentation this morning entitled A Multi-Component Integrated HIV-HTN Care Model that improves hypertension screening and control in rural Uganda. And this is an implementation science and a cluster randomized trial. So the prevalence of hypertension is increasing among people living with HIV across sub-Saharan Africa, and in Uganda, it currently ranges between 20 and 29%. The capacity to diagnose, treat, and control hypertension remains suboptimal. Major gains registered in HIV care and treatment for people living with HIV have led to a reduction in HIV-associated morbidity and mortality. There is a growing push to integrate HTN screening and treatment services within HIV care in Uganda, and a critical need to understand how providers can better adopt and implement HTN-specific protocols in HIV practice. However, little data exists on the effectiveness of integrated HIV and HTN care delivery systems on blood pressure screening and control. So using the PRECEDE framework, we designed the integrated care model intervention to address barriers to integration of HIV and HTN care among people living with HIV. We hypothesized that the integrated HIV-HTN care model intervention would increase HTN screening, treatment, and control among people living with HIV in rural Uganda. And we tested this hypothesis with a cluster randomized trial, and we enrolled people living with HIV who are 18 years and above from 52 public health centers, and these were 2 health centers per district. And in total, we had 26 health centers in each arm in rural southwestern Uganda. Our unit of randomization was the district. Just talking more about the model, as I earlier mentioned, that we used the PRECEDE framework to design our intervention, and some of the identified barriers highlighted on my left. And they included provider and patient knowledge gaps that affect their practice. There was fragmentation of HIV and hypertension services, and if a patient had both illnesses, they came to the clinic more than once to seek for HIV, and also return on another date to seek for hypertension care. There was inadequate reporting system within the health management information system, and there was also lack of performance feedback at the facilities. There was also lack of provider motivation to conduct the hypertension screening, as well as a supply of essential HTN drugs and other essential supplies. And so, based on these barriers, we designed a multi-component intervention, and it had 3 major components. The first one is training and capacity building, where we developed an integrated HIV-HTN training manual. And this manual emphasized the importance of screening, early diagnosis, and treatment of hypertension in HIV care. We trained providers, and here we trained about 3 providers per clinic on integration of HTN in HIV clinics, and we provided support supervision and mentorship to the clinics to discuss implementation and its barriers. And this we did monthly for the first 6 months, and then this was conducted quarterly for the rest of the implementation period. We also had promotion of hypertension screening and care in the HIV clinics, and here we emphasized on training on mandatory screening of all patients that present to the HIV clinics. And so if a provider received a patient who has come for HIV care, they made sure that this patient was screened for hypertension. We also provided information on HTN and HIV during routine health education within the HIV clinics, and we had HMIS enhancements through mentorship and coaching, and ensured that providers were given information on how to collect data and fill the NCD registers and also the patient care cards, and also have the data captured within the electronic medical record system. Performance feedback meetings were conducted with providers for them to understand how the implementation is going, but also to discuss with them if there were any barriers that were arising throughout the implementation period. And the last one is what we call rapid technology-enabled feedback between the DHOs and the providers, and in our systems, the DHOs are the managers at the district level who oversee healthcare delivery. And so we created WhatsApp groups where providers and their managers would communicate, but also we had our teams as mentors to strengthen feedback and answer any questions that come through the discussions. We also conducted detailed stakeholder feedback discussions to share the best practices as implementation was going on. For our measurements, we conducted cross-sectional surveys administered to a random sample of patients at baseline, 12-month, and 24-month, and we aimed for 50 HIV patients per facility and also 50 HIV and hypertension patients in each sample. Pre-specified analysis, we used TML, accounting for clustering, and our primary outcome is screening for hypertension in prior 6 months. And this we compared between arms at 24 months of implementation. Our secondary outcomes include initiation of treatment, hypertension control. Here we considered hypertension less than 140 over 90 millimeters of mercury. And we also looked at the presentation of participants with severe hypertension, and that is 160 over 100 and above millimeters of mercury. This we compared within intervention between 12 and 24 months among patients with a prior HTN diagnosis. Moving on to results, our baseline survey, like I mentioned earlier in the methods, we conducted 3 surveys, one at baseline, 12-month, and 24-month. And at baseline, we enrolled 2,645 patients with HIV, and these were balanced between arms. 54% were women, 47% were aged 40 years and below, 64% were married, and 66% were farmers. And this was distributed across the arms and for the surveys at 12 and 24 months. At baseline, only 2% were known to have HIV and HTN. In this table, I will not go into the details, but it just shows a balance across the different time points when we conducted the baseline 12-month and 24-month. But to note is that the proportion of patients who were presenting with both hypertension and HIV increased from 2% to 28% by month 24 of the intervention. Moving on, I earlier mentioned that our primary endpoint is HTN screening. And at 24 months, hypertension screening was 77% in the intervention arm compared to 22% in the control arms. And the risk difference was 55%, which was statistically significant. These effects were seen for all the subgroups, and we see for women, it's at 53%, for men at 56%, adults aged 18 to 40 years at 55%. And this is shown again on my left, the graph that is indicating a good distribution between control and intervention, and they were all significant across the different subgroups. We also went ahead to look at the effect of the intervention in terms of improving hypertension diagnosis over time. And I present 2 graphs by arm. One is control with orange color, and we note that at baseline, we had 25 patients, and by 24 months, there were about 184 patients within the control arm. And when you move on to the next graph, which is in blue, you will notice that there was a dramatic increase in the number of patients diagnosed with hypertension by 24 months, which is from 24 patients at baseline to 809 by month 24. We also went ahead to look at the patients who were on treatment among our participants with prior diagnosis over time. And again, a similar distribution. We noticed that our intervention improved HTN treatment over time among the patients that were reporting prior diagnosis. So looking at hypertension control, and this we report within the intervention arm only, and hypertension control improved from 33% at 12 months to 57% at 24 months. And this is a risk difference of 24%, which is statistically significant. We see that the improvements were seen across other subgroups, as highlighted in the graph on my left, with a sky blue indicating month 12 and deep blue indicating month 24. And there was an improvement seen across the different subgroups. We also tried to understand whether our intervention affected the patients who present to the facility with severe hypertension. And looking at the intervention, we looked at a reduction in severe hypertension, and that was grade 2 and above. Those patients who are presenting with a BP measurement of 160 over 100 and above, and we report a reduction in the number of patients reporting with severe hypertension from 32% at 12 months to 13% at 24 months, and that represents a risk difference of 19%, which is statistically significant. This was observed across all the subgroups. And in conclusion, the integration of HTN in HIV care delivery systems is feasible and urgently needed given the current rising prevalence of hypertension among patients with HIV. And our integrated care model improved screening, treatment, and control for hypertension. However, we note that within the intervention arm, HTN control at 24 months still remained suboptimal at 57% of our participants who reported prior hypertension achieving hypertension control. And we still noted that 13% of our patients were still reporting with severe hypertension by month 24, which still remains suboptimal. We have noted some persistent barriers throughout the implementation period, and some of them include intermittent distribution of hypertension drugs from the sources, which is the Ministry of Health, the unmet need for screening of other NCDs. Our project was focusing on hypertension. However, we know that the burden is bigger than hypertension, and so the gap in screening, especially for the diabetes, is still wide. The genetic structure barriers to HIV care still trickle in when we move into hypertension care. We still notice human resource constraints, the heavy workload on the providers, the shortages, and also the staff transfers after training. Data utilization is still suboptimal, and these we have seen them remain, and the team is thinking on how best to address them in future. So addressing these gaps will definitely require innovative strategies, which will include better drugs and continuous training for the providers, but also strengthening the healthcare system to leverage the synergies of chronic HIV care and treatment. I would like to acknowledge my team members. This project is implemented by a consortium which is coordinated by the Infectious Diseases Research Collaboration, and the members of the consortium are Makerere University, UHI, which is the Uganda Heart Institute, the Ministry of Health, and London School of Hygiene and Tropical Medicine, and our other collaborators, University of California, Berkeley, UCSF, our study participants, and I'd like to acknowledge EDCTP for funding this project. Thank you.
Thank you, Jane, for a very interesting presentation. I think there are some questions. I see hands up. Do we have a mic?
Thank you very much, Ms. Kabami, for the great presentation and for this great study that looks at practical intervention to help people with HIV and hypertension. So my question is on your first slide and your conclusion. You note that there is high prevalence of hypertension among people living with HIV. But I would like to refer you to a study published by the Makerere Lung Institute that showed hypertension as one of the highest risk factors for severe COVID-19 and or even dying of COVID-19. So it seems hypertension is sort of an evenly distributed risk factor in Uganda. So I don't know whether you would confidently say that it's high among people living with HIV/AIDS without doing a prevalence study that compares HIV negative and HIV positive people in the country. What are your thoughts about that?
Yep, thank you so much. I think on the whole, there's an increase in prevalence of hypertension, both in the HIV negative and positive. But I think our main concern is the comorbidity situation with HIV and the complications that it comes with. But I agree with you that it is not only in the HIV positive that you're observing an increasing trend in prevalence, but it is on the wider. And also, our focus was on the HIV clinics. But when we are training providers, you know that in the different settings, we don't have specific providers for only HIV positive patients. So in terms of capacity building, we have built capacity for both HIV, for providers who see HIV patients, but also those that are in the outpatients to ensure that there's improved screening and early diagnosis at that point. Thank you.
Yes.
Hi, I'm Claire Calderwood from the Through Zim team in Zimbabwe. I wanted to ask two related questions. The first one was, you mentioned medication access as one of the barriers to hypertension care. And I just wondered what had happened about medication access during the study, whether you'd done any specific interventions in order to try and improve medication, for example, supplying them through the study, and whether you'd sort of monitored what medications were available over the course of the study, whether that had improved in order to support the better treatment that you presented, and specifically what medications were being used. And then related, one of the things we've seen in some of our work is that often clinicians want additional tests such as ECGs or renal function, particularly for people who've got severe hypertension before they start treatment. And I wondered if that was something that had been offered as part of this study, what the diagnostic workup was, and how that was paid for, whether that was paid for as part of the study or something that's offered as part of routine care in these clinics anyway. Thank you.
Thank you so much for the very interesting question. And the first one was concerning treatment. I did mention that there was an improvement in treatment over time during the implementation period, but also I highlighted it as a barrier. And so the concern is whether we're able to monitor and what was done. I will mention that at the beginning of the study, we did not have provision of drugs as part of the intervention. However, as I mentioned at the beginning again, I said this is an implementation science study. And so you learn as you implement, and you also get feedback from the other implementers and providers. So by year 2, we noted that the problem was still persistent, and the project had not been set out to provide drugs for other patients. And so we continued working with the Ministry of Health and also the facilities, but we provided a buffer stock from the project that would provide for patients drugs in periods when the supply would be not available and out of stock. And so that we did for both intervention and control, because it was not part of the intervention. And so we provided a buffer stock for from 12 months to 24 months. And we are still discussing with the ministry. We have an in-country meeting scheduled by end of this month, where we hope that we can use these results and findings to advocate for more drugs, for better drugs, and also for a better supply, even after the project has closed. The second question was about diagnostics. I would say that our project is a little bit out of the scope of the project, but it's something that we have discussed and we are thinking as a team in terms of the next steps. But in terms of the scope of this project, we worked within what was available and provided us by the Ministry of Health. So we did not have any diagnostics as part of the diagnosis. We only conducted the measurements, and if you're hypertensive, we gave you treatment based on the Ministry of Health protocols. Thank you.
Thank you very much. Can I just ask, did you have combination drugs or not?
Yes, sometimes, and other times based on what is available. So it was really driven by the availability of the drugs at the clinics and what drugs are available. Thank you.
No more questions? Okay, then a big thank you, Jane, and congrats. You might have noticed that this is slightly unbalanced, gender unbalanced team, which is great, because like 20 years ago it was completely the other way around. But we have a next presenter, Andrew. Karibu. Welcome, Andrew Peter Kiazi from Makerere University in Uganda. who is going to present latent tuberculosis infection among people with diabetes in Uganda and Tanzania. Andrew, the floor is yours.
Thank you very much for that kind introduction. I'll be presenting latent tuberculosis infection among people with diabetes mellitus in Uganda and Tanzania on behalf of the PROTID consortium. And I declare that I have no conflict of interest. So we know that tuberculosis remains prevalent in Africa, and statistics from the IDF show that diabetes mellitus is predicted to increase both globally, but even more in Africa compared to other parts of the world. And there has now been a well-studied relationship between diabetes and TB, where diabetes confers about 3 times risk for TB. And even when we have a combination of both, the outcomes tend to be worse. About 15% of patients with TB also have diabetes. What was the rationale for this study? To eliminate tuberculosis, we have to tackle the global reservoir of latent TB infection, where the patients with diabetes mellitus lie. So we thought screening and providing of preventive treatment for latent TB in patients with diabetes can contribute immensely to this goal. So we sought to estimate the burden of latent TB in diabetes with the hope that this will guide in addressing future challenges that may come with this dual epidemic. The aim of this study was to determine the prevalence and determinants of latent TB infection in a large adult DM population in Uganda and Tanzania. So this is just part of a bigger, larger study funded by EDCTP, part of the randomized double-blind placebo-controlled clinical trial that's assessing the efficacy of rifampicin and isoniazid to prevent tuberculosis among patients with diabetes. And it's a work package 1, which is a cross-sectional screening phase of this trial. And this lies in objective 4 of work package 1. This map just shows the different partners for this study and clinical trial. The clinical trial is being conducted at 2 sites in Uganda, Makerere University and Uganda Matters Hospital, Rubaga, and in Tanzania at the KCRI Moshi and the NIMR Mbeya, with great support from partners in the United Kingdom, the Netherlands, New Zealand as well. In this study, we enrolled 2,005 diabetes patients from the 4 different sites who are 18 years and above, and we basically screened them for 3 things on top of taking a clinical history. So we screened them for HIV for those who are not known to have HIV, and then we also screened them for latent tuberculosis infection using 2 tests. So we did use the interferon gamma release assay, quantiferon plus, as well as a tuberculin skin test that was placed and read 48 to 72 hours after. We also excluded active TB in all participants by doing a chest X-ray on all participants, regardless of their symptoms reported, but also we did, using the ICF WHO questionnaire, ask about the TB symptoms. So active TB was suspected in those who either had a positive symptom screen or an X-ray that was suggestive of TB, or even both. And those did get a sputum gene expert and culture on top of this. Just one slide back. So at the end of the day, our major outcome for this particular objective was latent TB infection status. To the results, key things from this table: majority of our participants were female, about 72% of them. We had a median age of 57 years, and the median DM duration for our participants was 7 years. And the HIV prevalence in this group was about 8.2%, and near to 5% did report a history of active TB diagnosis or treatment. To the latent TB infection prevalence, we found that it was high at 56.3, distributed across the different sites. As you can see, it was lowest in Moshi, in Tanzania at 35.1, and highest in Kampala at both the sites with a prevalence of about 77%. And Nimrimbeya had a prevalence of 59.6. With the factors that we explored to be associated with the latent TB infection in this population, we found that those who were overweight and obese had increased odds for latent TB infection in this population, and other associated factors included an age between 35 and 55, having a history of previous TB, as well as being a contact to a TB patient. We found that the female sex was not associated with an increased risk for latent TB infection. However, in this study, other risk factors or other factors that had been studied and found to be associated with latent TB infection risk, like smoking, use of the metformin, and alcohol, we did not find an association between these and LTBI odds. To the tests that we used, so this is one of the few unique studies that has done a prevalence of latent TB infection using both TST and IGRA, and 38.9% of our participants had a positive TST, and 43% of those also had a positive QFT+. The intersection, 25.7% were positive on both TST and QFT. The agreement was 72% with a kappa statistic of 0.42. So we think there is a high prevalence of latent TB infection in our population, and this is consistent with other prevalences that have been documented in other African and Asian studies, although this tends to be a bit higher than previous studies. And latent TB prevalence that we found here is comparable to other risk groups like household contacts and people living with HIV in the region. And we are studying in the group underlying mechanisms that may explain this relationship. And we have a PhD student who was doing a poster presentation trying to explain this at this very forum. But we think the chronic inflammation seen in type 2 diabetes patients may lead to immune aging and exhaustion that may then impair immune responses to tuberculosis. And our associated factors, apart from those that I did mention, were consistent with those that we found from other similar African and Asian studies. So to conclude, again, message is we have a high latent TB infection prevalence among diabetes patients in East Africa. But we also now believe that systemic testing for latent TB infection in this DM population is feasible, although we cannot overlook the few challenges, especially with the latent TB infection testing modalities, especially IGRA. The treatment of latent TB infection in this population, we think, can hope to prevent the progression of latent TB infection in diabetes patients to active TB, which will then help to achieve, which will help the goal to achieve the elimination of active TB. And currently, the PROTEID clinical trial, which is ongoing, we hope will be able to inform us about this efficacy of this preventive treatment, the safety, but also the cost effectiveness of this therapy in this DM population. I would like to acknowledge the PROTEID consortium in the picture on my left, partners from Uganda who are leading on this work package, Tanzania, Netherlands, UK, and New Zealand. And would also like to acknowledge the EDCTP that is funding this clinical trial and also funded this work that I'm presenting today. Thank you.
Thanks for a great presentation, Andrew. The floor is open for discussions, questions. Yes. I see many hands up. That's good.
Thank you, Mr. Chaze, for the great presentation on latent tuberculosis, which is a big challenge. You used IGRA and TST, and I don't know whether you're aware that IGRA also misses a number of like 30% of the latent TB positive. So I don't know whether you thought about that in your study in terms of screening for latent tuberculosis infection. The other point is that you've just left us hungry because your study is about prevention of development from latent to active TB, but you have not presented the results of what you have seen so far because you got the latent cases, but have you done any management of those and have you prevented them from becoming active TB? Thank you.
Thank you very much for those brilliant questions. So part of why we structured this study to use both TST and IGRA, among other reasons, was the fact that we know each of these tests has its own challenges. Of course, the TST with the inter and intra variability, but also the IGRA misses quite a number, especially because it requires quite good technique and intensive procedures for you to come up with a good result. So this was at the back of our minds, and that's why we structured the study to use both TST and IGRA. And what I didn't mention was that participants were categorized as latent TB positive if they were positive on either or both. Thank you. And then your second question, so like I said, the clinical trial is ongoing. The data is not yet available for analysis, but once it's available, we'll be back here to tell you more about that.
Yeah, but just adding on that, are these patients treated? Are they?
Yes.
Okay.
Yes, so this is just work package 1. It's a screening phase, so all latent TB positive patients from this study flow on to the clinical trial, which is work package 2, where they receive 3 HP, which is isoniazid rifampicin weekly for 3 months, or placebo.
Yes.
Thank you very much, Andrew. Okay. Thanks, Andrew, for a very good presentation. I just want to confirm from your findings. Of course, we have a statement which says that disease does not read books. From your results, we have seen that more female have higher prevalence of tuberculosis, which is somewhat very different from more studies. We have seen that tuberculosis more in male. I don't know, is there any explanation on that why there is more prevalence for TB infection in female in your study?
I'm sorry, I think that was a bit of a misrepresentation. So the high female dominance was in the whole study, so 72% of our study group were females. But like I mentioned in another slide, the female gender was not associated with increased odds for latent TB infection, which is consistent, like you have said, with other studies.
Thank you. There is a question over there, yeah. And then we're coming back this side.
Thank you very much, Andrew, for the excellent presentation. In trying to explain the high prevalence of TB in diabetes, you said chronic inflammation in obese patients. We see many patients with DM who are not obese, so does it mean that they don't have chronic inflammation?
That's right.
And in your studies, are you observing that DM type 2 is in obese patients? Because we see many who are lean and they have DM. Secondly, we have a very active TB program at the Ministry of Health. I would wonder why they are not partners so that they put these findings in policy. Otherwise, it will take long to influence them to put this in policy. Thank you.
Okay. Thank you very much. I'll start with the second question. So, yes, the MOH is actually part of our partners. Sorry, I didn't mention that. But back to the obese picture. So our median BMI in this population was about 27.7. Not obese, but these clearly are overweight patients. And in another DM phenotypic study by Davis, who is also part of the group, he did find indeed a substantial number of diabetes patients in the Ugandan population. About 30% were actually lean. But interestingly, he also did find that these patients, although they were lean, had dyslipidemia. So we still think the picture that we see in the obese patients, I think still applies even to the lean, especially if they have dyslipidemia.
Yes, next question.
Hello. Thank you very much for your presentation. Two questions. One is, if I'm interpreting correctly, you showed an adjusted odds ratio for female that was lower, that was actually 0.5 something, with a statistically significant confidence interval, showing that female groups were less likely to have latent TBI, tuberculosis. Not that it was not associated, but it was lower, actually, the odds of latent TB for female compared to male. Is that correct?
That's correct.
Okay, thank you. Yeah. Second thing is the kappa between IGRA and TST. It's very low, and that's really concerning about the different tests that you use for that. So that's another thing that was kind of concerning about what test to use, because that's not resolved. And the last question is, how long are you following the patients in your trial? Thank you.
Thank you. Yeah, so I do agree the kappa was not a good one for the, agreement between these tests, and it's consistent with so many other studies that have attempted to use both. Like I said, each of the tests really comes with major challenges, especially in a setting like Uganda or Tanzania. So again, we'll not make strong recommendations, but the TST will be a preferred one for our setting because it's cheap, it's easier to teach to so many providers for TB compared to our IGRA. I beg your pardon on the last question.
How long are you following the patients?
Oh, yeah. So we are following these patients for 24 months from the time that they are enrolled into the trial for outcomes of active TB.
Okay, just a short comment. I'm from Argentina, and we work on TB and diabetes, and we also test for TST more than IGRA because of your reasons. Not reliable and expensive for us. Thank you.
Thank you.
So maybe there is a new collaboration starting here. Yes, thank you. Time for one more question. Then we have to move on. No hands up. Okay, thank you, Andrew.
Thank you.
Thanks. So, and the last but not least presentation is from Rashida Ferrand and from the London School of Hygiene and Tropical Medicine, who is going to talk about comorbidities in children and adolescents growing up with HIV. Rashida, floor is yours.
Thank you, Marlene. I'm not going to present one single data set. I'm hopefully going to convince you that we really need to be focusing energies beyond provision of antiretroviral therapy. So, as you know, that we've had remarkable global scale-up of antiretroviral therapy, which has done three things in children. It's dramatically improved survival so that we're seeing very large numbers of children with HIV entering adolescence and adulthood. So we've increased lifespan. We've seen a decrease in HIV infections in children due to effective prevention of mother-to-child transmission due to delivery of ART to pregnant mothers. And we've also seen a decrease in incidence of HIV-related infections infections and opportunistic infections, both in adults and children. But coverage of antiretroviral therapy in children still remains disproportionately lower compared to that in adults, and we are still observing a very delayed diagnosis, so that historically delayed diagnosis in Africa particularly, which has 90% of children living with HIV who did not start ART in infancy. So the question that arises, and I want to pose to the audience, is whether ART is necessary, but is it sufficient? So we know that there are sequelae of immunosuppression, for example, recurrent infections, for example, individuals who've had meningitis, who have residual kind of neurological deficits, people who've got residual lung infections, who've got lung impairment. We also know that there is inadequate immune reconstitution, which I will show data on, and compromised protection from vaccines, even in the era of antiretroviral therapy. The other things that might potentially cause us concern beyond delivery of ART is that there is residual immune dysregulation, particularly in a large proportion of children who have started antiretroviral therapy much later in childhood. And so timing of ART delivery and initiation is critically important. Of course, in children, we are starting antiretroviral therapy in children related to their timing of infection at birth compared to in adults. So they've got much longer exposure to drugs and really immature and less developed physiological systems to metabolize antiretroviral therapy drugs, which potentially puts them, along with the other two factors, at higher risk of multimorbidities. And these multimorbidities then lead to disabilities and a decreased health span. So what I'm proposing today is for us to focus beyond increasing lifespan to focus on increasing and improving health span. Clearly, from delivery of ART and development of multimorbidities and disability will be mediated and modified by factors such as nutrition, socioeconomic factors, and access to and quality of healthcare provision. So I'm going to now present some data that brings some of these issues out. So the first thing is the timing of antiretroviral therapy initiation. So this is a very large CIPHER collaboration that published this data in 2018, included 38,000 adolescents, 65% were from low-income countries, and 79% were from Africa. And what you can see on the bar chart on the left is that age of ART initiation in cohorts from Africa were much, much, much longer and later than cohorts from the United States and the UK and Europe. So the median age of ART initiation in Africa was 7.9 years compared to 0.9 years in the global north. And this is not just a small cohort. This is representative of what's been happening across Africa. And these are children who've now started to have entered adolescence. The other thing you can see in panel B and C is that median CD4 count at starting antiretroviral therapy was much lower in African and South Asian cohorts, and really lower height for age and stunting visible again in South Asian and particularly African cohorts, which persisted despite antiretroviral therapy. So this is a really important study which kind of shows us a global picture of what is happening. Then the question around sustained immune reconstitution. It's a really interesting study published in 2022 from the CIPHER collaboration, which has about 11 networks, HIV networks across the globe. And very interestingly, what you're beginning to see is that CD4 counts are declining across adolescents, and these are in individuals, adolescents who've started antiretroviral therapy and have remained on antiretroviral therapy, which begs the question, are we seeing adequate immune reconstitution in children who are started on ART? Clearly, the question might arise that some of the children represented in these studies might have been those that started ART in early 2000s and therefore had lower CD4 counts. But even when adjusting for year of starting ART, these patterns are being seen, not just in children in Africa, but across the globe. So we do not measure currently CD4 counts routinely in children and adolescents, but we really need to think about, is the job done with antiretroviral therapy? Are we seeing some sort of decline in immune reconstitution and immune ability in children growing up with antiretroviral therapy? Okay, so I want to just touch on a couple of few morbidities which we really know about and which really receive much less attention in antiretroviral therapy clinics among children. So the first one I want to focus on is growth failure. Now, I think everybody in this room will be aware that children experience severe retardation in linear growth and pubertal delay, which is much more marked in sort of particularly in low income settings, largely probably because of nutrition and because of the infectious milieu. And why does that matter? Why does being shorter matter? Because we know from the literature in children, even in the non-HIV, in children that are not growing up with HIV, that stunting is associated with increased mortality, delayed physical and cognitive development, and poor educational attainment. And it's one of the really critical areas that we need to focus upon in children, improving stunting or decreasing stunting. And stunting obviously becomes more obvious in adolescence when you get a growth spurt and puberty developed. And importantly, again, if you look at the CIPHER cohort data, which was published last year, which had 20,000 adolescents with HIV, that essentially, what the collaboration showed that those with the most extensive and marked stunting, which were really from East and Southern Africa, Botswana, and again, Africa basically, had really the highest gains in growth, i.e. they did get a growth spurt when they started antiretroviral therapy, but they did not achieve the kind of growth potential that they should. So if you started antiretroviral therapy, that does not necessarily get you to optimal growth. And really the other thing that they observed in this study was that the stunting was most marked in individuals, in children who had had delayed ART. And we are not going to change in the adolescents growing up today. Many of them, the vast majority of them in Africa, have started ART after infancy. This is sorry, if I can just go back, I want to make the point that it's not just about stunting. Stunting is also associated with impaired musculoskeletal development, and there's a very close interaction with pubertal delay and poor linear growth. So, you know, it's not just growing up with shorter, but it also has an impact on the quality of bone and muscle that children have as they're growing. And remember that adolescence is the period when you have a really steep sort of developmental period of your muscles and bones, after which you achieve peak bone mass around the age of 20 to 22. So in this study that was done by colleagues in our group, what this PhD student of ours did was to look at musculoskeletal development and particularly size-adjusted bone density. And I'm just going to show you the data for lumbar spine bone mineral apparent density Z-scores on the left-hand panel. And what you can see is that if you compare HIV-positive adolescents or peripubertal adolescents who are HIV positive compared to HIV negative, that across the Tanner stages 1 to 5, you're beginning to see much lower LSBMAD Z-scores in those who are HIV negative compared to HIV positive. Much more impaired in positive children compared to those who are uninfected. And really, it's very, very important, particularly in the girls at Tanner stage 5, because they're going to need those bone reserves as they start getting pregnant and breastfeeding. And we've really not paid sufficient attention to kind of bone quality and bone density. The other finding that was really important in this related study, again from Zimbabwe, from our group, was that age of ART was really strongly associated with the LSBMAD scores. So that those who had started antiretroviral therapy beyond the age of 8 years, which is the median age of starting ART or has been in Africa, that was associated with more than 1 standard deviation reduction in LSBMAD. And if you look at literature from kind of non-HIV settings at what bone mineral density of less than 1 standard deviation means, that is enough or equivalent to a doubling of fracture risk in adulthood. Clearly, we are not seeing this there at this stage, but it kind of gives you a hallmark for future problems in adulthood, as these children will be entering adult HIV clinics. And the point, so we've got a trial currently, and thank you EDCTP for funding that, of vitamin D, high-dose vitamin D and calcium supplementation. And the trial lead, Nyasha, is in the audience today. And we will be unblinding that trial at Victoria Falls. It's a multi-country study between Zambia and Zimbabwe, so at the border. And we hopefully hope to come back to EDCTP forum to present the results of those of that trial. But beyond growth, there is also observation of multi-system impairment across a number of organ systems: cardiac, respiratory, neurocognitive, and much less known about renal disease. And this is data from the CTAC cohort in Cape Town, led by Heather Zar's group, of a group aged 9 to 14 years. Again, all of these children were antiretroviral therapy. And I think this data speaks for itself, that you've got a pretty high burden of both single, dual, and multi-system morbidities in children growing up with HIV, or peripubertal adolescents growing up with HIV, compared to those who are their uninfected peers. So I just want to touch on a couple of these. It would take me ages to go through all of these, but just so that I can highlight what our research, some of our research priorities should be beyond delivering art. So our group has defined a novel form of chronic lung disease. Again, we give people ART in clinic, but 20 to 30% of children in our clinics do have chronic respiratory symptoms, usually hypoxia, which we don't look for, chronic cough, inability to exercise adequately or optimally for their age, and poor lung function. These are not things that we look for, and children begin to take this for granted. And when we've done investigatory studies, what we see is a very distinct lung disease affecting predominantly the small airways. This is very different from the lymphocytic interstitial pneumonitis that was defined as the most common cause of lung disease in the pre-antiretroviral therapy era, and which has sort of pretty much melted away in the era of art. So you can see what the differences are. So on the top right panel, you can see a a picture very much affecting interstitial tissue of lung on a high-resolution CT scan. On the bottom, which I'm afraid doesn't project very well, but you can see areas of mosaic attenuation, which are very strongly associated with FEV1 or a marker of obstructive airways disease, which would be very characteristic of small airways disease. And again, we don't do HRCT scans in clinics, we don't do X-rays routinely, and when people present, or children present, or adolescents present with chronic respiratory symptoms, we recurrently treat them with antibiotics and or TB therapy as a kind of trial of TB treatment. But they continue to have these chronic symptoms, which then becomes almost part of living with HIV. So again, the importance of focusing on health span. Importantly, this chronic lung disease has been observed to the risk increasing with age and occurring despite antiretroviral therapy. Again, I won't go into cardiac disease, but there has been a paucity of studies in the ART era. I'll just cite Dr. Majonga, who's an EDCTP fellow, who's presented her findings today, but her PhD studies showed that using transthoracic echocardiography, a quite high prevalence of both diastolic dysfunction and left ventricular hypertrophy. And importantly, hers were one of the few studies that actually followed individuals up and showed an incidence of any cardiac abnormality of 8.8 per 100 years. Importantly, the large majority of her cohort, as other cohorts, are pauci-symptomatic. They don't present with cardiac symptoms, so it's not something that we look for. And the disease mechanisms are very unclear, and I hope Edith and other colleagues in the room will be going on to kind of really interrogate some key questions. Are we beginning to see myocarditis and fibrosis? Is this secondary to lung disease? Or potentially how much vascular disease is there, both coronary vascular disease and or vascular disease in the rest of the sort of vascular system? So these are really important questions that we need to be addressing, because these children will enter adulthood with underlying cardiac disease, both structural and functional dysfunction, both structural and functional disease. The other area which is much more recognized is neurocognitive disease. Again, I don't have time to go into the complexity of this disease, but if you look at the DSM manual for mental disorders, you can see that neurocognitive domains fall into these 6 categories. And what most studies have shown, and I'm summarizing hundreds of studies that have been conducted across Africa and have focused on the African literature rather than literature from the global north. And what you're seeing is that in the early days of the epidemic, we used to see a very severe global HIV-associated encephalopathy with sort of, not reaching milestones, kind of real motor dysfunction in babies born. But what we're seeing in adolescents today who've started art is something much more subtle. We're seeing deficits in executive functioning, processing speed, working memory, and visuospatial ability. And indeed, we've got an embedded study funded by EDCTP embedded within the Vitality trial called the Vitality Mind, which really very much echoes the findings that have been observed in CTAC cohort, but across several cohorts within the African continent. And this is critical both for art adherence, but also educational attainment, and multiple studies show that children and adolescents with HIV are behind in terms of their educational milestones. And this will have impact on their employment, their risk behavior, and potentially also associated with neuropsychiatric disease. And then when we think about neuropsychiatric disease, the studies are poor. They're largely cross-sectional, often lack comparison group, and lack validated instruments to measure disease. But if you basically look at the studies that have been conducted, we see a prevalence of between 20 to 50% in cohorts from Kenya, Malawi, Rwanda, and Uganda. And this is a very nice meta-analysis published, which I've cited there, which show a psychiatric diagnosis on the background of very high prevalence of common mental disorders, which include anxiety disorders, major depressive disorder, including suicidality, and behavioral disorders, including attention deficit hyperactivity disorder. And we're seeing particularly higher risk of depressive disorders in HIV-infected as well as affected adolescents. And this, as I said in my first earlier slides, that etiology of this is impacted by a range of biopsychosocial factors, not just HIV and its biological effects. So for example, bullying, lesser schooling, failing school, family death, and lack of disclosure. So it's biological, but a very strong interface with biopsychosocial factors that result in neuropsychiatric disease. But unfortunately, in our clinics, we really have to date focused predominantly on delivery of art and reaching viral suppression. And remember, all of the studies that I've presented today are amongst children and adolescents who are on antiretroviral therapy. And we have very limited awareness, services, access, and uptake. So ultimately, we've got these diseases, but importantly, our children and our adolescents who are entering adulthood are living with disability, which is often invisible to healthcare providers and which is absorbed and visible in the community, in communities, which often marginalize them. This is a study from one of our PhD students through ZIM, and it was done in children aged 6 to 16 years, where the median age of diagnosis was 5 years, and these children had a median CD4 count of 726, so they were largely immune replete, or compared to kind of severe immunosuppression, and 75% had an HIV viral load of less than 400 copies per mil. And we used they used a Washington Disability Questionnaire, and compared a cohort of children and adolescents with HIV to an HIV negative control group that was age and sex matched. And what you can see is that any child that with HIV, the odds ratio of having any disability was 2.8. So, you're much higher risk of having a disability if you're living with HIV. And, again, the pattern was similar across several domains of disability. And I think you can't see it until you see it. And these are just some pictures from children, or rather adolescents in our clinics. So this is a young 16-year-old with really severe musculoskeletal disability who remained in a wheelchair, taking antiretroviral therapy, unable to go to school. The degree of stunting is, again, pretty remarkable. This is a 16-year-old on the right with his younger sibling. And taking antiretroviral therapy. And on the right is again an adolescent who'd had recurrent eye infections and ended up having a chronic uveitis and a subsequent corneal perforation. So I think what I want to end with is really that we're focusing on increasing lifespan, and that certainly should remain a focus. But we do now need to both invest research and our programming to improve health span so that we ensure that the children we have invested so much in end up with healthy lives. So HIV programs do need to shift beyond focus on the HIV care cascade, of course ensuring timely diagnosis and attaining viral suppression and maintaining suppression remains a key focus. But we do need to have an increased awareness of comorbidities. There's been a much bigger focus on comorbidities in older people people who are adults and growing old with HIV, but our children are also growing older with HIV. There's very little understanding of the natural history and pathogenesis of these conditions, and these children are going to end up now in adult clinics in larger and larger numbers. We need to develop screening, diagnostics, and therapeutic strategies. And again, I'd like to thank EDCTP for having funded a trial to start thinking about, that thinks about musculoskeletal disease. And importantly, we shouldn't forget that those who already have disabilities also warrant attention from us. We need to be focusing much more on management of disabilities, including particularly educational support and mental health interventions, alongside delivery of biological therapeutics and antiretroviral therapy. So I think this has been a bit of a whirlpool, but really my aim with this talk is to kind of just ask colleagues in this room and beyond that we really need at this point to not stop at viral suppression, but I think even having an indicator that goes beyond the 95, 95, 95 targets to having 95% of both adults and children having a healthy, an increased health span. So I'll stop there, and I'd like to thank scores of people in my group who work on comorbidities in HIV, and many of the colleagues on the continent and internationally who are focusing on comorbidities. Thank you very much.
Thank you, Rashida, for a fabulous presentation. Indeed, a wake-up call, and it's not enough to tick the boxes like, this and this and this, but that we have to look beyond this. Questions?
Thank you very much. Your call is very important, and we need to take heed and do something. Throughout your speech, of course, you mentioned Africa quite a lot. I can't remember the number of times you did mention Africa, which means it was one of the main focus of your studies. Just wanted to know, in your CIPHER network, how many African countries are represented in your network, because Africa is a large continent. Secondly, stunting is something that is actually always mentioned. And I was wondering whether you think HIV or antiviral treatment is the cause, or whether the cause could be a bit wider than just HIV. And how practical do you think the kind of screening and diagnosis and care that you're advocating would be for the health systems to adopt in order to be holistic as you propose? Thank you.
Thank you for the three great questions. So I'm not personally a member of the CIPHER network. It's work presented by, it's work done by the CIPHER network. I can't remember the exact countries, the number of countries in Africa, but what I can tell you is that more than 2/3 of children in the CIPHER cohorts were from countries in Africa. It wasn't one country, it's multiple countries. I will look up after that and come back to you about the number of countries. And indeed, I don't think it's unfair to have a large representation from the African continent, because the vast majority of children living with HIV are in Africa. And so I think the attention to Africa, particularly for children, is apt. The second thing you asked is whether stunting is related to HIV. it is absolutely multifactorial. It is not just due to HIV. Nutrition, genetics, infectious milieu, in fact, any insult affects growth, right? Emotional disorder, I mean, if you've got emotional kind of not sufficient love and care, that affects growth. And there are lots, potentially growth experts who can talk to you much about that. But even if we allow for that, we do know that HIV is associated with stunting, independent of those factors. But it isn't the only factor. So if we are not going to address stunting by a simple nutritional intervention or simply by antiretroviral therapy. And the important thing is that once somebody is stunted, even if you start antiretroviral therapy, they're not achieving their growth potential. Those are the important things. So I completely agree with you. It's not just a simple HIV causes stunting. There's a very complex framework for growth to occur. Thirdly, our health systems, I would quote what Prof. Abdul Karim said this morning, is that, we've often held back by saying things are not possible because our health systems are weak. And I think it's up to us as scientists to produce evidence that shows that this matters and to sort of develop innovative approaches and contextually relevant approaches to manage, beyond delivery of art. So I'm a half glass full person, and I believe that improvement in care and provision of holistic care is not only possible, but in fact that it is a human right for all, not just those in high-income countries.
Thank you. There is a question in the back. And then
Hi, Rashida. Thank you for a lovely, lovely talk and overview. And just to say a little bit about CIPHER, because we were involved with that.
Yes.
Obviously, the data are quite old now from CIPHER, although it's continuing to give a really useful baseline as to what's happening.
Yes.
And hopefully, things are getting a little better with,
Agreed.
in terms of changing treatment, etc.
Yeah.
My question, Rashida, was your HIV negative kids, are they HIV uninfected but exposed kids? Because obviously that's critical, knowing that the data that's coming out from various places about the exposed but uninfected children, of which there are so many in places like South Africa, who don't have necessarily everything that HIV truly negative and with negative families have. Yeah, just commenting on that. Thanks.
Really two excellent questions. I agree that, the age at art initiation has dropped. Many of the kids in the children in the CIPHER cohort were children who started art late, but they are now in adolescence. The reason they're still important is because they're going to enter adult clinics. And the other point to make is that we are not there yet, and Dai, you know this more than anybody, is that we still have a large proportion of children whose diagnosis is delayed. And the proportion of children who are not diagnosed with HIV is much higher than proportion of adults. We always cite a success in terms of 95 targets, but children have been served much more poorly. So we're still not there yet until we either eliminate and get every child started on art as soon as they're diagnosed in infancy. These problems do remain. So I think you're right that the point I want to make is that this matters because this is a life course that is set when children are born and when they are started. And I think that you raise a really incredibly important point is that I presented data for children who are living with HIV, but there's such a wealth of increasing data that shows that many of these complications that we are seeing, for example, neurocognitive dysfunction, some growth impairment is also being observed in children who are exposed but uninfected. And we are going to see, until the adult HIV epidemic ends, we are going to see a large and growing number of children who are exposed and uninfected. And that's another problem confronting the pediatricians and the pediatric experts like yourself, Dai, because they also have they also are at risk of some of these comorbidities, perhaps less marked. And again, kind of like mixed in with the biopsychosocial circumstances that they are at higher risk of. But it absolutely is another area that merits a lot more research.
I think there was one more question. No? Yes.
Yeah, thank you for a very nice presentation. In one of the slides that you showed the decline of CD4 count with age, did you also consider the normal range at each of the specific age? Because
Yes.
usually it's tend to...
Yes. So again, this is, as Dai says, these are children that are from kind of older cohorts. So, you may well have representation of children who started at lower CD4 counts. But I think it is an interesting finding that despite that over time, these large networks and cohorts are really important in showing patterns. And globally, there is a decline slowly over CD4 counts, and we don't quite understand why. And again, whether this is happening in adults as well. These were for age appropriate, which I hope answers your question. But it is, again, a question that is important because, we do have a proportion of children who don't achieve adequate immune reconstitution, but also the question remains, does that remain stable over time? And we almost stopped, particularly in settings where I work, doing CD4 counts. We just do viral loads. But should we be focusing on CD4 counts still?
Thank you, Rashida. I also had a question because you said about 2/3 of the children were from the African countries.
Yeah.
So 1/3 is from somewhere else.
Yes.
Did you look at differences in disabilities?
Well,
depending on countries or continents or situations where the children are growing up?
Thanks, Marlene. So the CIPHER cohort essentially presented data largely. So the first CIPHER publication, which I'm really fond of, I have to say, because it tells a lot of stories, albeit with the limitations of large cohort studies, looked at age at starting art, stunting, and CD4 counts. And we saw, again, quite remarkable levels of stunting in South Asia and Southeast Asia. And I think many of you who work in that region will know that we already have very high background levels of stunting in South Asia and Southeast Asia. So it's not surprising that we see that. So in terms of disabilities, there wasn't any data on disabilities in this paper or in this network. I'm sure they're analyzing such data.
Thank you so much.
Thank
a big
you.
clap. We have 3 minutes to the end of this session. I think it was a wonderful session with 6 great presentations, a very active and interactive audience. So I would like to thank all the presenters. Another round, a big clap for them, please. And all of you for being here, for staying till the end, for asking questions. And I want to, of course, also thank my co-chair for leading this session. I wish you a very good afternoon and see you in one of the next sessions. Thank you.
Thank you very much.
So that went well, timely.
Very well timed, very well timed. I was afraid that my laptop was giving up because the connection, the plug doesn't seem to work. That's why I had a backup, so